Hello everyone, welcome to The Voice of Nursing. My name is Adrian Tracy, I'm the CEO of ICG Medical. Today we're very lucky to be joined by Terri Salt. Terri, welcome to The Voice of Nursing.
Thank you.
Terri, tell us a little bit about your background.
So, memory test this one. I trained a long time ago as a nurse, as a registered nurse in both adults and children at the Hospitals for Sick Children, Great Ormond Street, Charing Cross and Queen Charlotte's Maternity Hospital in London. And I remained in clinical practice for a good few years and gained experience and qualifications in paediatric intensive care, paediatric respiratory nursing, palliative care, as well as infectious diseases. But then I had my own children, and that made clinical practice and working shifts really complex. So I moved out of providing direct care into lecturing and tutoring, and then from there into management as the children got a little bit older. I started as a regulator at the turn of the century, actually, which now sounds quite a long time ago, almost by accident. We had moved and I wanted part-time work. A job with the local authority was advertised, and until that point I'd never even thought about regulation. I don't think I even knew it existed, but it seemed to match the criteria for what I wanted, and I've been in regulation ever since. My substantive post is an inspection manager, but I've recently completed a secondment to act as the head of hospitals inspection for North London.
So you are a CQC inspector for the care quality?
Inspection manager with the care quality, with the Care Quality Commission, yeah.
What is that? A lot of people hear about the CQC.
The CQC, okay, what is it? That wasn't on my list of questions. Sorry. That's all right. So the CQC is the Care Quality Commission. It's the regulator of all health and social care services within England. We just cover England, we don't cover Wales and Scotland. And our job is to monitor, enforce where people breach the regulations, drive improvements in healthcare, report on the healthcare arena and market through the state of care reports, to look at changing pathways of care, to inform government policy, and to keep at the heart of that the patient voice, the patient experience, to make sure that they're actually central to all that we do. So the way we regulate has to be to ensure that people are safe, that they're well cared for, that the care they receive and treatment they receive is effective, and that the services are well led.
And what's the sort of key role of an inspector within that?
So the inspectors carry a portfolio of services. We work predominantly in 3 directorates. There's an adult social care directorate, a primary medical services directorate, and an acute hospitals directorate. I work in acute hospitals. My team each carry a portfolio of services where they build relationships, where they monitor the quality of care in those services on an ongoing basis. But then they work in teams with specialist advisors to actually inspect services against a very clear framework to check they are compliant with current legislation, and to report on good practice and to share that good practice.
And this is what we talk about. We hear about the ratings.
Mm-hmm.
Tell us a little bit about ratings in the CQC.
So there's
range, go up to...
Right, we go from. We assume that there is a default setting of good. We expect services to be good. I think everyone has a right to expect services to be good, and we go in expecting to find good services. Unfortunately, there are sometimes shortfalls where they're relatively small and have not a huge impact. They might be rated as requires improvement. Where services really aren't meeting the standard that's required, where you wouldn't want your mother, daughter, sister, brother, son, cousin to be cared for, they get rated inadequate. Sometimes they get put into special measures, which is a multi-agency term really. We don't put them in, we recommend it. NHSI puts them in. And then going above good is the outstanding rating for those services, and it's about 5 or 7% that actually provide a service that is above good. It goes above and beyond the measure that would be expected.
And this is across the framework of 5 domains, is it?
5 domains, yeah. Or 5 key questions. Are they safe? Are they effective? Are they caring? Are they responsive? That's about individual need, access and flow. And are they well led? They're the 5 key questions around our inspections. So each inspection has a core service for NHS trusts or the whole hospital if it's an independent healthcare service. So one inspector might inspect children and young people services to see whether they're safe, effective, caring, responsive and well led, yeah.
And how often do you do those inspections? Once a year, twice a year?
We're just consulting on the frequency rules. For NHS trusts, we had committed to going in every year to review the leadership and some of the core services. But that's not realistic, it's not feasible, we haven't been able to keep to that time frame. It's become very burdensome for both the provider and for us. So we are consulting on lengthening that where services are good or outstanding. Obviously, if a service is inadequate, we'd go in more frequently. We'll go to a far more risk-based approach where we want to drive improvements to make sure that nobody receives inadequate care.
And how, I know we're speaking briefly off camera, but how do you get outstanding?
How do you get outstanding?
Sort of top 3 things that are
top 3 things.
Or that you read in a book, but you've obviously done a lot of case studies, you've seen a lot of different people.
Yeah.
What are the sort of key components you think actually, as you say, it's only the top 5 to 7%?
It's the top 5 to 7% in hospitals, and I think, I may be sticking my neck out here, I think I certainly awarded or recommended the first outstanding rating nationally. I think I've probably recommended or awarded the most outstanding ratings for any NHS trust generally. So I've been involved in a lot of services where they have been rated outstanding. And as part of a book that I'm writing, I actually did some research with inspection staff and said what did they think outstanding was. And almost without exception, they said, you just know.
Okay.
You just feel it. You then have to evidence that, but you can walk into a place and you know that it's outstanding. And I think there's an element of truth in that, because I think the sort of intuitive observation, intuitive assessment goes on, that you perhaps have to stop and think, why am I thinking this is outstanding? And the key things is about good leadership, outstanding leadership, that creates a positive culture that builds on strengths and good practice. And where staff have bought into that ideal and want to provide good care. And it becomes slightly cyclical because good care is cheaper, of course. If you've got adequate resources to provide care that meets people's needs, you have less pressure damage, you have less falls. So actually, you're saving money by providing good care, because falls and pressure damage cost the NHS an absolute fortune. They're hugely expensive, apart from the personal cost to somebody that's fallen and broken their neck or femur. So it becomes cyclical, but it's about leadership, it's about culture, it's about getting the basics right before you start. And one CEO of a trust in London said, swinging from the chandeliers, that brilliant basics magic touches. You have to get the basics in place and doing well, and then you have to do more on top of that. But that has to be about your staff wanting to do more. It has to be about ideas coming from your staff. It has to be around keeping the patient at the very centre of everything you do and personalising care.
And obviously, it's a challenging role. What do you sort of see them as sort of most challenging element of the job?
I guess the most challenging part has to be dealing with inadequate care. Nobody likes seeing it. I still get pleasure from going into a service that's outstanding, that's good, and seeing people get really good care. That's still a nice feeling. It's lovely to be able to report the staff like you're doing it, the patients are really happy. It's just a really nice feeling, and it's very easy to write a good report. When you know that you're going to make a service inadequate, it's much harder, because you have to remember that's people's jobs on the line. It's actually looking at how you make the provider make the changes to improve the experience for patients. It's potentially people's registration, if you take them to the NMC, or the GMC because of the failings you found. And I don't think there's anybody that wants to do that. Nobody wants to go in and find inadequate services.
No.
As much as most healthcare professionals don't want to provide inadequate services.
Don't they say no one goes to work
Nobody goes to work to do a bad job. So actually that creates an emotional impact that is hard, actually. It is hard sometimes.
So the challenge part is writing the report, is the challenging part?
The challenges are actually deciding to do it, I think, and deciding within your team and getting consensus, but then communicating with the provider and the staff about the outcome. I don't think we should ever walk out of a building leaving a provider unclear if there are that level of concern. It has to be honest and upfront. And it is difficult and it is a challenge to communicate that, and people do get upset or angry, understandably. But we have to do what's right.
Yeah.
You have to do what's right by the people that use the services and by the staff.
And obviously you can't name names, but have you had one of those stories where you've turned around, or you've worked with a client that has become inadequate and gone to maybe good, if not outstanding?
Oh, I mean, you can name names because they're in the public domain.
Okay.
Certainly I've walked alongside isn't quite the right word, but I have seen services transformed, certainly.
Okay.
And that's a really nice feeling.
Yeah.
So the one that comes to mind was East Sussex Healthcare Trust, a huge combined trust in East Sussex that was placed into special measures where there was significant lapses of care, where the staff morale was very low. They had a new CEO and a new chair of the board who were absolutely committed to changing the culture and took action within a week or two. And I was back there last week, and that bit about just feeling, I walked in and it felt different. The staff weren't looking at the ground and sitting with their arms crossed, they were looking you in the eye and smiling, and that's a really nice feeling. And the data behind that, the detail, shows that actually there is a real journey of improvement in things like their mortality rates are falling. They're getting better.
Yeah.
So actually the data supports the view that they're improving, and looking at specific areas of care around things like their end-of-life care across both the acute trusts and the community. It has been transformed.
How do they go about doing that?
They have that comes down to leadership that builds a culture where the staff trust them, that sets a vision that the staff can believe in, where they believe that if there's people behaving inappropriately, bullying or being unpleasant, the executive team will deal with that and deal with it effectively, so they feel safer and more secure to raise concerns and to say, hang on a minute, I'm not sure we should be doing that. Where they start listening to each other, where they can actually see it's nice to provide the good care. Executive leadership, local leadership, driving that culture of positivity, where the staff turn around and think, actually, no, we want to do this, we want to do it well.
Sounds like a lot more of an open culture.
Much more open culture, much more trusting culture, much more transparent, and supported by their own staff, but also the agencies that are involved in the trust can see where the trust is going. They can see the difference it's started to make in terms of the finances. They can see those have made a really, I mean, they're not perfect yet by any stretch of the imagination because they're in such strong deficit, but actually you can see there's a way out, there's light at the end of the tunnel.
Yeah.
And I think that glimmer of light at the end of the tunnel makes staff think we can get there.
Gives people hope.
That their aspiration can be met, they can do it, and I think that's what a good CEO does. It tells them they can do it.
And you've obviously come from the nursing, now you're into the education, now you're into the inspection side of things. What are the sort of top 3 lessons that you've learned over the course of your career?
Well, I'm still learning, I think.
That's a good thing.
And still learning about what I'm learning. I still get surprised sometimes. The top 3 things, and I think I've come to them quite late to really understand what they mean. I think the top 3 things are about reflecting, taking time to stop and think, why did that go wrong or why did that go so well? and acknowledging that when something's gone wrong, you might have had some impact on that. And thinking about how you could have done it differently and how you'll do it differently next time to make it better for yourself, for other people, for staff, for whoever. So I think that reflection is really important. I think as a nurse, my primary piece of learning, and again I was quite surprised a couple of weeks ago when so many people didn't even know what their code of practice said, and it was a room full of nurses. I think being true to your professional code of practice, valuing it, I think knowing that nursing is a profession that is probably the most respected profession in the country, comes out as number one every time, and actually each of us has a role to play in that. And so my key lessons would be reflecting, upholding your code as a nurse, or actually as a doctor, your own code, but for me it's a nurse, so uphold your code of practice and know your code of practice. And within that is all the other lessons, which are about actually make sure you strive to be the very best you can be. We can't all be outstanding, we can't all be the chief nurse for England, but we can all do the best we can possibly be.
Obviously we're a nursing channel. What do you sort of see the main challenges for nurses at the moment? You know, obviously in the social care and in the acute setting.
The challenges, I think, are huge. I think the greatest challenge is not knowing what the future is going to look like for many, not being able to plan effectively because you don't know the impact of all the political instability that's going on at the moment. Brexit, we've got to mention Brexit, is going to have an impact, but we're not quite sure of the level or the extent of that. It could mean that our hospitals are very, very short of nurses as we failed to recruit from Europe. But equally it could mean that we're able to attract a wider range of nurses from across the wider world. I think that not knowing is a real challenge. I think resourcing is a real difficulty, and again I think that's the opposite cycle to excellence. You know, people see deficits in budgets, so they start asset stripping, which means that services are under-resourced more and more, so staff morale falls, so care gets worse, and you can get into a really negative cycle, and I think that's a real challenge for nurse leaders to try and overcome, to prevent even rather than overcome, to actually be at the front and saying, yes, we need to save money, we need to stop any wastage, we need to be efficient. But we do that by improving care, not stripping out the resources to deliver it. So I think resourcing is a huge challenge. I think the other challenge is an exciting opportunity as well, and that's that the range of options that are open to nurses now. You know, when I trained, graduate nursing was only just coming in. So if you're a nurse for life, on the whole, until you wouldn't have babies or whatever. But actually now you're a graduate and all those graduate jobs are open to you. But even within nursing, there's a huge range of options. You know, you might be the chief nurse for England or the director of nursing of a large acute trust, but equally you might work part-time in a travel clinic. You might do a clinical nurse specialist, doing endoscopies. You might be a practice nurse. There's just so many options and so many that actually that almost makes it harder to decide where you're going to be, and that's a challenge for individual nurses. Where do I want to go and what do I want to be? But it's also a challenge for the traditional bread and butter nursing roles to attract people into them.
I think they're saying that like a ward nurse is going to be like a specialist role moving forward, because a lot of people go into, as you say, different specialist avenues,
different specialities,
or primary care,
but also I think that technology and advances in medical research and medical treatments mean that it has become far more specialised. When I was training back in the day, children with cystic fibrosis rarely made it to adulthood, and now they're living through heart-lung transplants, double lung transplants, into their 40s, 50s, and there is an expectation they'll have an adult life. And that means they need far more specialist care and far more specialist nursing. So actually that's an opportunity for nurses, but it's a challenge for people that want to recruit generalist nurses.
It's also new, isn't it? It's because
It's new,
children haven't lived that long before with those sorts of conditions.
And that's true for so many things. Cancers, cancer is still perceived as a death sentence, but most women with breast cancer now live and survive. But you need clinical nurse specialists alongside them to actually provide the care and treatment to allow them to live well.
And are you seeing, what sort of trends are you seeing in nursing in sort of short-term wise in the next year or so? Is there anything that you see coming out in the nursing areas?
I think there's more innovative use of staff to innovative use of staff to fill gaps where they haven't been able to recruit registered nurses, and I think that's huge opportunities for many staff. So HCAs that are going on developmental pathways, apprentices recruited at a very young age going on developmental pathways up through HCAs.
You see much of the nursing associate role?
And nursing associates and different roles and different ways of using staff, and I think that's a really exciting way of introducing people into the healthcare field and possibly onto registration. Personally, and this isn't necessarily the view of CQC, I think we have to be aware that outcomes for patients are better where the nurses, they have care from registered nurses. So I think those other roles support and work alongside registered nurses. I would have concerns if there was a view that they could replace registered nurses. Care by registered nurses improves patient outcomes, proven time and time again. So I don't think we can ever do away with registered nurses. I think nurses will move far more into postgraduate education and actually be more powerful because of that, a more powerful voice, individually and collectively. If you've got a director of nursing that's a doctor of nursing, they can hold their own very well against perhaps medical doctors where they've previously been seen to be the slightly lesser partner. I think actually having very well qualified postgraduate nurses supports nursing overall and helps develop research within nursing, helps, and allied health professionals, helps develop nursing practice in the same way that medical practice is developing. And I see it very much that nurses work alongside doctors, but they're complementary rather than either subservient or the same.
There's a change in that, isn't there? That's kind of been changed over the last few years, isn't it? It's the doctor, where now it seems more of a team.
I've never been subservient.
Maybe not yourself. But, you see them more as a team.
Actually,
because we've had doctors on here and they say they've learnt more from a nurse than they've learnt from their studies.
I think generally there probably is better team working, not just with doctors and nurses, but with physiotherapists, with speech therapists, dietitians, coming together collaboratively with the patient at the centre, and that has to be a good thing, where everyone understands what everybody else is doing. That has to be a good thing.
Talking about outcomes.
It has to improve patient outcomes where everyone's clear about what the outcome needs to be and how that's going to be developed.
And then looking to make sure they don't get resubmitted.
Yep.
All that sort of stuff seems to be a lot more collaborative, talking about different areas. It is the physios, as you say.
It's everybody.
The social area, everyone working together.
Yeah.
Seems to be a lot more going on.
Actually, it's the housekeeper and the ward maid who's given them a cup of tea and they say, oh, I'm ever so worried about, who sometimes picks up those real nuances of care that all the professionals that perhaps dealing with a very specific issue don't see, but the person that's coming and dishing out their cup of tea knows full well they're really, really worried about their cat that's been left at home and they don't think anyone's going into it. And that's just as important as the plaster on their legs.
Yeah. That's the mental health, isn't it?
Yeah, absolutely.
And so you touched on it briefly. You have a book deal.
I do have a book deal.
We didn't know we had a famous author.
No, it's not famous yet because it's not published yet. It won't be published until the autumn.
Tell us about the book. Or, sorry, multiple books, may I ask?
Well, a brand and a series, yeah. It's quite a new thing in terms of I only got offered the deal about 3 or 4 weeks ago. And it is hugely exciting. And the brand is towards outstanding. And I think it comes about because so many providers, when I meet with them, say, so how do we become outstanding? Well, how do we get that become one of the elusive 5%? And I don't think we really give them that answer. It's not our job to give them their answer, they need to work it out for themselves. But actually there's not really the support for them to understand what it is that makes them jump up that rating. So the book is based on case studies where people have reached the outstanding rating or also services that are good but have aspects of outstanding. And actually even services that are RI, some bits of it can be outstanding. And it's about building on that really good practice to spread excellence, and that can only be done through good leadership, through organisational development, and through looking back and reflecting on what is it that makes that bit of our hospital, our care home, our service outstanding, and not the rest of it.
And is it 4 books you mentioned?
So it's a textbook and a training pack that will be used hopefully by providers, and then supporting books for the participants and the leaders of using that training pack.
So other than doing all these inspections, writing books...
Yeah, the books are in my leave.
I was going to say, what do you do outside of work? What do you do in your spare time?
What do I do in the spare time? Well, my children are all now beginning to move on, although they seem to be home just as much as they were when they were at school. And the house is going to be heaving at the seams for Christmas. But we had a Dalmatian dog given to us about 18 months ago. We weren't thinking of getting a dog, we certainly weren't thinking of getting a Dalmatian, but he has changed our lives. So I don't shop anymore, we don't go for city breaks, we go to walk on the beach and on the downs. And my husband runs with him every morning, which is really good for my husband. I don't run. But actually we live in a really beautiful area of the country, and the West Wittering and East Head beaches are stunning, and walking there with the dog on a Sunday afternoon in the wind and the rain is absolutely lovely. Yeah, it's really very therapeutic. He's very sweet, he's very pleased to see us, but he is energetic. And he eats a lot.
Is there any message, Terri, you'd like to share with our nurses?
A message with nurses. I'm not sure I'm in a position to tell anyone what to do or how to be, but I think actually the key message for both regulated service providers and individual nurses, organisations, is actually with all the technology, with all the advancements, with all the opportunities that are coming along, I think why nursing remains the most respected profession is because that first line of our code, and that has never changed over the centuries. You can go back to Cura when it was ancient Greece, and nursing has remained constant ever since, which is that it's about compassion, it's about respect for the individual patient, it's about keeping that person's needs and preferences at the very centre of all you do, and kindness. And I don't think at any level a nurse should step away from that. And I think one of the reasons I'm proud to be a nurse is because all the nurses I've worked with have kept that and understand that that is what nursing is. You know, whether you're performing as a surgical first assistant, whether you're in a practice prescribing antibiotics for a toddler with earache, whether you're working in a prison, actually that kindness, that compassion, that respect for the individual has to remain central to everything you do. And if we lose sight of that, we lose sight of our profession.
Superb. Terri, thank you so much for coming on The Voice of Nursing. Yeah, no, not at all. Thank you to everyone for watching The Voice of Nursing. Thank you to all our nurses, our doctors, our allied health professionals, and everyone who looks after us. I will look forward to speaking with you again soon.